Dr. Ken Landa. Thanks for watching. Let's talk about bacterial vaginosis. This is an interesting condition that represents the overgrowth of bacteria that are normally present in the vagina. It's one of the most common causes of women seeking care in gynecologists' offices. More than 10 million visits each year. And when we look at women who have bacterial vaginosis, 50% are asymptomatic. That means that there are about 20 million episodes each year. So that means that this is the most common cause of vaginal discharge in women. Well, what's the likelihood that a woman's going to suffer the condition at some point in time? It's going to be between 30 and 50%. And once you have the condition once, very frequently it's going to be recurrent. Reason to be concerned, even if it's asymptomatic, it increases the risk of your acquiring a sexually transmitted infection if you happen to be exposed. And there's a very real risk that if you're pregnant, it might cause some mischief with the pregnancy. So it's currently referred to as a dysbiosis. It's the imbalance of the bacteria that are normally present. So the organisms that are normally predominant, well, they slow in growth, and the organisms that represent only a minority of the bacteria present, they become the major bacteria present. So it's not really an infection the way most people think of infection, like a boil on your skin or a pneumonia. So by agreement, it seems that Lactobacilli are the most common organism that are present in the vagina, and for some reason, the Lactobacilli decrease in their growth, and when they decrease in their growth, then some other organisms start to grow. Well, how did the other organism get there? Was it introduced by sexual relations? Was it introduced by digital manipulation? Was it introduced by some other mechanism? We just don't know how the organisms get there, but we know that the Lactobacilli are very common. We've known that since the late 1800s. It seems that from the 1800s up until the mid-1950s, it was just a non-specific vaginitis. But then in the 1950s, it was discovered that there was a bacteria. And the bacteria at the time was given the name Haemophilus. And that Haemophilus bacteria, now called Gardnerella, that seemed to be associated with the condition. So it was referred to as a non-specific bacterial vaginitis. But then in the 1980s, it was thought, you know, this organism doesn't seem to be the major cause, and we don't seem to have a condition where we have those inflammatory cells, so we shouldn't call it vaginitis. The itis, itis, in medicine tends to refer to infection, like appendicitis or diverticulitis or pneumonitis. So let's call it bacterial vaginosis instead. And indeed, when women who have bacterial vaginosis are evaluated, they don't seem to have the associated increase in the white cells, the inflammatory cells, that we would find if a woman had gonorrhea or herpes or trichomonas infection or even a yeast infection. So what are the complaints? Well, first of all, 50 to 70% of women don't have any complaints. But the other women complain of a malodorous vaginal discharge. That's extraordinarily common. Smells sort of like rotten fish. Sometimes the discharge can be profuse. It's more noticeable after sex and often recurs with the menses. The color is off-white to gray. It's thin. But there's no pain during sex, no dysuria when you urinate, no redness, no swelling, no vulvar irritation. So we have the vaginal discharge. We have the vaginal odor. Sometimes there are bubbles in the vaginal fluid. The pH, or the alkalinity, seems to be increased. So it's more alkaline than acidic. But under normal circumstances, the vaginal pH should be more acidic. So is the acidity a major factor? Well, probably not, because if we look at prepubertal women who don't have the condition, they're more alkaline. If we look at postmenopausal women, the same thing, more alkaline, but no infection, no condition. So how do we make the diagnosis? Well, the diagnosis is made if a vaginal discharge is present, and 2 or 3 other factors. If there's no discharge present, you need all the 3 other factors. What are the 3 factors? The 3 factors are the presence of what are known as clue cells. So take a Q-tip inside the vagina, smear some on a microscope slide, look under the microscope, and find some of the cells that have desquamated from the vaginal wall. Those are just simple cells that normally line the vaginal wall. Now you're on your Q-tip, so you put them on a microscope slide, you look, and they're studded with bacteria. That means it's a clue cell. And it also gives us good information when we do this simple test, because we can exclude acute inflammatory cells. We don't see those white blood cells that are there. We also don't see yeast infection. We don't see the trichomonas. So it gives us a lot of information, simple from swabbing with the Q-tip. Then we can also do a simple test for the pH. When the pH is more than 4.5, that's relatively alkaline. Normally the vagina is much more acidic. And then we can do the whiff test. So the whiff test is taking a little bit of potassium hydroxide, putting it on the slide. It breaks down some of those cell walls around the cells that line the vagina. And when it does that, it releases some amines that are present. Well, the amines have the tendency to smell like the fish. So with the AMCEL criteria, you need 3 of 4 for the diagnosis. You need 3 or 4 of these conditions: the discharge, the clue cells, the pH more than 4.5, and the odor. And if you have those, 3 of those 4, 70% chance that you have the condition. Now people are saying, well, maybe you only need 2 of those 4. Okay, so 2 of those 4. It's a little less sensitive, but it still gives us the clue. Now, at physical examination, what do we find? Not terribly much of anything. The labia, the introitus, cervix all appear normal. There's little or no evidence of any inflammation in the vagina. The vaginal discharge, as I mentioned before, it's gray, it's thin, it's homogeneous, tends to adhere to the vaginal wall rather than pull in the back of the vagina around where the cervix is. Well, what are the risk factors? Now, people talk about all sorts of risk factors, and they probably don't account for all that much. So what are the risk factors that people talk about? Well, it's having multiple sexual partners, even female sexual partners. And the sex doesn't really matter whether it's oral or vaginal or anal sex. Seems that if a partner is not circumcised, that increases the risk. But some women have never had sex at all. According to the military, when they look at the recruits, as many as 15% of women without a history of any sexual relations have bacterial vaginosis. Being unmarried or having a new sex partner, beginning sex at a relatively early age, taking antibiotics seems to increase the risk. Because remember, if you take an antibiotic, it's going to change the bacteria all over the body. Or cigarette smoking can affect your body's ability to fight bacteria. And that happens not just in the mouth and in the lungs, but it happens throughout the body. Women with an IUD are at greater risk, as are obese women. Women who have a history of prior pregnancy are at risk. Women of lower socioeconomic status seem to be at greater risk. But what is the real cause? Just don't know. How did the bacteria get there? Just don't know. But they get there somehow. Now, does douching help? Well, the Department of Health and Human Services strongly discourages use of vaginal douche, even after sex or exposure to lubricant or feces. They say no boric acid douches, no homeopathic suppositories. They say that the vagina is normally able to maintain a healthy balance of the bacteria, and if you douche, what you can do is actually flush some of those potentially harmful bacteria through the cervix and up into the uterus and the fallopian tube, something you want to avoid. Now, you go down the grocery store aisle or the pharmacy aisle, there are an enormous number of products that are offered for a healthy vagina or a healthy genital area. There are feminine deodorant sprays and all sorts of cleansers and washes and wipes and different kind of material. Washing should be non-irritating soap, non-foaming soap. Showers are much better than baths, by the way, and bubble bath seems to be harmful. Well, the question is, does bacterial vaginosis represent a sexually transmitted infection? And people have gone back and forth, and it really all depends on what the definition of sexually transmitted. Yes, some bacteria on the penis can get into the vagina. Are they the cause of bacterial vaginosis? No, because we've already established that 15% of women who've never had any sex can have bacterial vaginosis. So somehow the bacteria get there, and they do so with enormous frequency. So no, it's not a traditional sexually transmitted infection, and no, it's not contagious, even though we might find some of the bacteria on the penis or even in the urethra. So what about other sexually transmitted infections? Well, if a person has bacterial vaginosis, some of those bacteria are going to inactivate some of the host defenses and allow some of those bacteria potentially to get up through the cervix into the uterus anyway, going to gain access to the upper tract. So it is a risk factor. Why are you susceptible? What did you do to seem to get this kind of infection or this kind of a problem? And the answer is you didn't do anything. So it seems to come from your genetics and your host immune response over which you have no control, your ethnicity, oftentimes the environment that you live in, and seems to have something to do with the fluctuation of your hormones and even certain stressors. So if you look at African American women, they tend to have a higher vaginal pH and less lactobacilli. They have a more diverse population of bacteria. And that seems to predispose to the condition. So that if we look at African American women, their likelihood of developing bacterial vaginosis is somewhere between 50 and 80% during the course of a lifetime, as opposed to Caucasian women, where the incidence is about 23%, or about a quarter of the individuals, as opposed to Hispanics, slightly more, at about 30%. Seems to be lower in Asian women and lower in European women. Now, part of the reason that African American women seem to be at greater risk is because they have fewer of those lactobacilli, and the space is taken over by what we call bacterial vaginosis associated bacteria, that Gardnerella that used to be the Haemophilus, and a series of other kinds of organisms. And they seem to be the principal reason that the African American population seems to have a higher risk. Now, having bacterial vaginosis might pose some problems. And one of the problems is it might predispose you to contracting HIV, AIDS. So it seems that it allows passage of the virus into the tissues. Not only does it allow more readily transmission from the man to the woman, but it also increases the likelihood that the male sex partner, if he's uninfected, might get the virus, because it seems that the shedding is increased in bacterial vaginosis. The shedding of HIV is 6-fold increase in the shedding. That means the transmission is 3 times more likely than if the woman didn't have bacterial vaginosis. And it's estimated by some that 20 to 30% of all of the HIV in Africa is due to women with bacterial vaginosis. That alters some of the risk factors. And you're more likely to contract a series of other sexually transmitted infections if you do have bacterial vaginosis. So the incidence of PID is doubled, the incidence of chlamydia is doubled, gonorrhea is doubled, herpes doubled, reactivation of the wart virus, the HPV, doubled. So bacterial vaginosis, even if it's asymptomatic, might put you at increased risk. Interestingly, if you're pregnant, it increases the risk. Increases the risk of preterm delivery by about 2-fold, especially if you happen to have bacterial vaginosis in the second trimester. What's important to realize, about 10% of births in the United States are preterm. Increases the risk of spontaneous abortions in the first trimester by up to 500%. Increases the risk of premature rupture of the membranes and chorioamnionitis. Increases the risk of infection in the uterus after birth, postpartum endometritis. and can increase the risk of surgical site infections if a woman has a C-section or if a woman has abdominal hysterectomy. So realizing all of this and realizing that 50% of the women who have bacterial vaginosis are asymptomatic, should they be screened? Well, the current recommendation is it really doesn't help. So what are the other conditions that might mimic bacterial vaginosis? Well, there's candidiasis and trichomonas infection or herpes or chlamydia or gonorrhea or vaginitis from standard kind of bacteria, maybe E. coli or strep or something like that. Or in women after the menopause, maybe it's a desquamative inflammatory vaginitis or atrophic vaginitis. When you're seeing the doctor, there are some tests that can be done other than what I just mentioned, but those tests, those proprietary tests, don't seem to really add anything to the value. So if we look at women, we find that depending on their network of individuals who they spend time with, that seems to be associated now with the likelihood of this condition. That's called a sexual network. And it seems that in different ethnic groups, we have different kind of lactobacilli. So in Caucasian women, we have Lactobacillus cristatus. In Asian women, it's the Lactobacilli einers. In the Black and Hispanic women, it's diverse population. But not only do we have the kind of lactobacilli I just mentioned, and it's important to realize each of those lactobacilli has different variants, but we also have other kinds of lactobacilli, Lactobacilli gasseri and ginseng, etc., etc. So which one you happen to be colonized by, which one happens to represent the predominant organism, may or may not increase or decrease your risk for developing the condition of bacterial vaginosis. And bacterial vaginosis occurs when the other organisms, like Gardnerella vaginosis or vaginalis, and the Enterococcus, and the Prevotella, and the Egrithella, and the Mobiluncus, all those other kind of bacteria we don't even talk about. Well, those become the predominant organisms, and that's why an individual develops the bacterial vaginosis. Now, under normal circumstances, the lactobacilli account for somewhere in excess of 90% of all organisms in the vagina, and they produce some hydrogen peroxide and lactic acid, and they produce some proteins that kill other kind of bacteria. We call them the bacteriocins. And they help the body produce mucus, and the mucus puts sort of a blanket down, so it helps prevent other kind of infections. So that's all very important, obviously. Well, lactobacilli are thought to have started to colonize people back about 10,000 years ago when we added milk and cheese to our diet. The vagina seems to be a perfect local niche for the organism because it has low oxygen concentration and a high sugar concentration. So now we have the lactobacilli that are normally present, and we had the idea that this first Haemophilus, then changed to Gardnerella, might be very relevant, but they grew the Gardnerella in pure culture, and then they inoculated it into otherwise healthy women, women without a history of bacterial vaginosis. And what was the likelihood of them developing bacterial vaginosis? Well, they did it in 3 different groups. In one group, 2 out of the 13 women developed the infection. Another group, 7 out of 29 women. Another group, 11 out of 15 women developed the condition. So that means that there was somewhere less than about a 35% rate of infection, even if we put the pure Gardnerella right into the vagina. So that would seem to indicate, at least, that just the presence of the Gardnerella by itself, that's not the cause of bacterial vaginosis. And we can find, under normal circumstances, we can find the Gardnerella present in the vagina and the penis and the mouth and the rectum. You even find it in women who don't have any sexual exposure, but that's one of the reasons we suggest that you wipe from the front to the back. You even find it colonizing the urethra in the asymptomatic sexual consorts of women who have the condition. So if we look for Gardnerella vaginalis, we're going to find it in about 100% of women who have a history of bacterial vaginosis, and in women who never, ever had the condition, we still find it somewhere between 50 and 75% of the time. So it's gone from, well, Gardnerella vaginalis is the cause of the disease, to, well, it's just one of many bacteria that seem to be associated with it. But now, recently, there's been the reawakening in the interest because of the concept of a biofilm. The bacteria, once it gets on the vaginal cells, on the epithelial cells that line the vagina, well, it might be able to make certain kind of concretion, certain kind of glue, and stick to those cells. And then if enough of the organisms get around, you get a biofilm, and the biofilm is impervious to any of those factors that the body might produce to try to kill them. And that means that once you get over your bacterial vaginosis, you still have a group of cells that are there. So even though you thought you killed them with the antibiotic you took, no, you probably didn't kill them all because there's still some there, and they just have a tendency to regrow. You can kind of think of it like the bacteria that are present in the plaque that you have, or in the, if you have periodontal disease. And inside that plaque, we find that the hydrogen peroxide that the lactobacilli make can't get there. Lactic acid doesn't have anything to do with it. The antibiotics we treat with can't get inside that biofilm. So we have a condition where the Gardnerella might be causing other problems than we originally anticipated. Well, where did the recurrences come from? Do they come from the biofilm? Do they come from the gut? We've already said that the organism is present in the intestine. Do they come from your partner? Just don't know the answer to that. But we do know that inside that biofilm, there's not just the Gardnerella, but the Gardnerella brings along a heck of a lot of friends. And once all of those organisms get inside the biofilm, then it seems our therapies don't really touch them. So if that's going to be a mechanism, then we have to develop over a period of time something to get rid of the biofilm, other than the standard antibiotics, because the antibiotics don't work on the biofilm. So what kind of therapy do we usually use? Well, 30 to 50% of the women are going to get better without any kind of therapy, but 10 to 15% of the women not going to improve with a single course of therapy, going to have multiple courses. So we could use either oral or intravaginal antibiotics. So clindamycin is extraordinarily popular. It's a cream. It can be used nightly. Originally used it for 7 days, then for 3 days. Now sometimes just for 1 day, but you have to be a little bit careful in those relationships where the male is using a condom, because the clindamycin can break down the condom. You could take the medicine orally, the oral clindamycin, 300 milligrams. You do that twice a day for a week. But remember, it's an antibiotic, and if you take an antibiotic, it could cause other kind of problems with bacteria in other areas, like in your gut. Well, interesting thing happened. 1978, a woman had a sexually transmitted infection, and she also had bacterial vaginosis, and the idea was you treat the sexually transmitted infection first. So they did that, and they did that with some metronidazole. And the sexually transmitted infection went away, but so too did the bacterial vaginosis. And ever since then, metronidazole sort of has been the standard of therapy. Could be used as a topical gel, used nightly for 5 days. You could also take it orally twice a day for about 7 days. But if you take it orally, it might have some side effects, a metallic taste, nausea, might cause the white blood count to go low. And if you happen to be taking the metronidazole and then take some alcohol, that can cause problems. It causes you to flush and have palpitations and nausea and chest pain and vertigo. Also interacts with warfarin, by the way, the blood thinner. Metronidazole also happens to be effective against trichomonas infections. But now there's starting to be some resistance of the bacteria to the metronidazole. So then some new antibiotics have recently come on the market. 2009, tinidazole. It's very inexpensive, has a longer half-life than the metronidazole. Then there was another relative that came out in 2017, Solosic. Solosic costs about $300 for a course and doesn't prevent recurrences. So that's probably not a good idea, especially because the recurrence rate's up to 80%. 30% going to recur within 3 months, 50% going to recur within 12 months. Some women who have more than 3 episodes a year might consider some long-term suppressive therapy, maybe vaginal Metrogel, maybe twice a week for 3 or 6 months. Tend not to use too much of the clindamycin, because remember, that's an antibiotic, so it's not recommended as a preventive therapy. What about treating the male consort? No, remember, once you get that particular bacteria, whatever the bacteria is, this Gardnerella and all of its friends, once they are present, then they're present. It's kind of, you can think of it like the herpes. Once you get herpes, once you have that herpes around your lip, it's going to come back, and it doesn't seem to make any difference what you're doing. Well, the same sort of thing with the bacterial vaginosis. Once it's yours, hey, it's yours. You're not going to be reinfected, most likely. So the Centers for Disease Control says, hey, if you took the oral medicine for the initial therapy, now you get a recurrence, go to the topical therapy. Switch around. Well, what about women who are pregnant? There's no consensus, but it seems that maybe treating women before 22 weeks, if they have bacterial vaginosis, might be a good idea to reduce the likelihood of complications later on in pregnancy with the preterm birth. Certainly thought that if a woman is going to undergo a cesarean section or a hysterectomy, abdominal hysterectomy, or going to have an IUD placed, then before that you should undergo some kind of therapy. Over in the United Kingdom and Asia, they use topical antiseptic. Seems to work as well as our therapies here in the United States. Current idea about treating the male consort, like I say, no. What about probiotics? Are probiotics helpful? Remember, you have this amazing diversity of organisms inside the vagina, and how they all fit together, we haven't the slightest idea. So taking some as a probiotic, has it ever been shown to be effective? It's very popular, but is it effective? The answer would appear to be probably not. So that's the story about bacterial vaginosis. Some people think it represents an infection, but it's really not. It just seems to represent the overgrowth of normally present bacteria. So they just overwhelm the lactobacilli that are present. Or is it that the lactobacilli decrease in frequency because of some other reason that we don't understand, and then the other organisms overgrow, irrespective? In bacterial vaginosis, we have an alteration of the normal contents of the vagina, not introduction of a new organism. Not that you just acquired some kind of new infection, but just that the organisms present normally have just changed in their concentrations. Maybe it's due to sex, maybe it's due to hormones, maybe it's due to stress, maybe it's due to your genes, maybe it's due to your immune system. All of those probably play a role, but the exact role, we just don't know. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified so we post new videos. I appreciate your interest. I'm Dr. Ken Landau.